At 6 weeks postpartum, your pelvic floor, well, it is honestly only recovered about 50% of its baseline strength.
Right. Barely half.
Yeah, exactly. And the collagen holding your fascia together is essentially um, biological duct tape at that point. Plus, your structural ligaments are still just swimming in hormones that are literally designed to make them unstable.
Completely unstable.
Right. Yet, this is the exact moment society and honestly standard medical practice tells you you're fully cleared to jump right back into normal life.
It's wild, honestly.
It is. So we are tearing down that 6-week myth today. Welcome to the deep dive.
Thanks for having me. And yeah, the gap between cultural expectations and the actual biological reality of postpartum recovery is just staggering.
It really is. And we've got a massive stack of sources today to back this up, right?
We do. We've pulled together clinical practice guidelines, physiotherapy protocols, some really robust resources from the NHS, and primary medical literature focused entirely on tissue healing.
So our mission today, for everyone listening, is to give you a definitive, biologically accurate answer to a very specific, incredibly common question. How long after birth should you actually wait before assessing pelvic floor laxity?
And to answer that properly, we first have to deconstruct what you are actually feeling.
Right, because reading through the medical literature, the way society casually talks about being, loose versus what is clinically happening, I mean, those are two entirely different universes.
Exactly. They are completely different things. Clinically speaking, vaginal laxity isn't defined as a structural failure.
Which is what everyone assumes, right?
Yes, but it's officially classified in the literature as a patient-reported sensation. It is the subjective feeling of, reduced vaginal tone or gaping at the entrance.
Okay, wait, subjective.
Yeah, it is heavily reliant on your neurological interpretation. It's not an objective structural measurement.
Which really brings up the vital distinction between the sensation of laxity and the structural reality of pelvic organ prolapse.
Yes, that is a huge distinction.
Right, and since you're listening to a deep dive on pelvic floor mechanics, you likely already know prolapse is the anatomical descent of pelvic organs, like the bladder or uterus actually dropping into the vaginal canal.
Exactly.
But it's crucial to understand how prolapse is evaluated compared to laxity.
Right. So prolapse is evaluated through essentially objective geometry.
Geometry. Okay, I like that.
Yeah, doctors use diagnostic tools like translabial ultrasound, which images the pelvic floor muscles dynamically in real time. Or they use the POPQ system.
And the POPQ system, that's the pelvic organ prolapse quantification system, right?
Exactly. It's a highly specific grid-based measurement. A clinician physically maps the exact millimeter descent of the anterior wall, the posterior wall, and the apex of the vagina.
Wow, okay, so it's super precise.
Very precise. Prolapse is a measurable structural shift. Laxity, on the other hand, is a neurological interpretation of a sensation.
So you can have prolapse without feeling any laxity at all.
You absolutely can.
And on the flip side, you can feel intense laxity without any measurable prolapse whatsoever.
Exactly. And the sources point to this fascinating curveball here that explains why our brains get this so wrong sometimes.
Oh, the scar tissue paradox.
Yes, the scar tissue paradox. So a significant percentage of people have perineal scars from natural tearing or episiotomies during delivery.
And instinctually, we assume scar tissue feels tight and restrictive.
It does, and that localized restriction is precisely the problem.
Wait, really? The tightness makes you feel loose.
Yeah, it's wild. When scar tissue forms, it doesn't align perfectly with the original muscle fibers. It creates this localized rigidity and binds up the sliding layers of fascia.
Okay, so it gets stuck.
Right. So when you move, the healthy tissue stretches normally, but the scar tissue pulls asymmetrically.
Oh, I see.
And your central nervous system registers that asymmetrical lack of support and essentially misfiles the sensation. It tells your brain there is a lack of tension in the entire area.
So you interpret that misfiring nerve signal as looseness, even though the root cause is actually a restrictive, hardened knot of tissue.
Exactly.
You picture your pelvic floor as, like, a tension hammock supporting your organs. A prolapse is the hammock physically dragging on the ground.
Right, structural failure.
Right. But the scar tissue paradox is like having a knotted, tangled rope on just one corner of the hammock. The overall tension is completely thrown off balance.
That's a great way to look at it.
So the hammock feels wobbly and unsupported, and you assume the whole thing is permanently stretched out.
Yes. And treating that perceived looseness without releasing the localized knot in the fascia is completely counterproductive. You have to address the asymmetrical pull to restore the feeling of tension.
That makes so much sense. I mean, understanding that laxity is this complex sensation rooted in stretched tissues and sensory misinterpretations, it just explains so much.
It really does.
But to understand why assessing this immediately postpartum is biologically impossible, we have to look at the sheer biomechanical trauma the tissues just survived.
Oh, absolutely. The numbers here are just incredible. During a vaginal delivery, the levator ani muscles, that's the core load-bearing group of your pelvic floor,
Right.
they can stretch up to 250% of their resting length.
250%. I mean, the mechanics of that stretch are just difficult to wrap your head around,
Very difficult.
especially when you consider a standard skeletal muscle fiber. It usually tears if you stretch it just 20 or 30% beyond its limit.
Exactly. So to reach 250%, the entire architecture of the muscle and the surrounding fascial matrix has to fundamentally warp.
And the body only accomplishes this through a massive hormonal cascade, right?
Yes, primarily driven by the hormone relaxin.
Relaxing.
Right. Relaxin actively alters the extracellular matrix of your tissues.
Okay.
It breaks down collagen and alters water content to make ligaments and fascia highly compliant.
Just incredibly stretchy.
Exactly. But the critical piece the standard 6-week clearance ignores is the metabolic half-life of these changes.
Right, because relaxin doesn't just evaporate the moment you deliver the placenta.
No, not at all. It lingers in systemic circulation for 5 to 6 months postpartum.
5 to 6 months.
Yeah.
And if you are breastfeeding, the hormonal feedback loop keeps relaxin active even longer.
Exactly. So you are trying to measure the permanent integrity of a load-bearing muscle group while it is actively being bathed in a hormone specifically designed to make it structurally unstable.
It's madness when you really think about it.
Mhm.
And we also have to look at cellular turnover, right?
Yes, the tissue repair process. When tissue is stretched to that extreme and sustains those micro tears, the initial repair phase relies on type 3 collagen.
Which is our biological duct tape.
Exactly. It's rapidly deployed, laid down haphazardly by fibroblasts just to quickly close the gaps.
Right.
But it has very low tensile strength and is highly prone to stretching.
So it's a very weak initial patch. And over the following months, you have this process called mechanotransduction.
Right, where physical movement signals cells to adapt.
Exactly. And that process forces your body to gradually replace that haphazard type 3 collagen with type I collagen.
Yes. Type I forms organized, highly cross-linked, parallel fibers. It acts as the structural steel of your connective tissue.
But getting from the duct tape to the structural steel, that remodeling process, that takes anywhere from 300 to 500 days.
300 to 500 days, which really casts a massive shadow over the standard 6-week checkup.
A huge shadow. The research shows that at 6 weeks postpartum, the abdominal wall has only regained roughly 51 to 59% of its original tensile strength.
Mm-hmm.
And the fascial layer of a cesarean scar is sitting at exactly 50% strength.
Exactly. So evaluating a pelvic floor for permanent laxity at 6 weeks is quite literally like measuring the load-bearing capacity of a concrete pillar while the mixture is visibly wet.
The foundation simply hasn't cured.
Not even close.
Since the underlying biology flat out forbids an immediate assessment, the chronological roadmap for recovery really requires a massive shift in expectations.
It does. And the clinical sources break this timeline down into distinct phases. It starts with weeks 0 to 6.
Which they call the acute foundation phase.
Right. During this initial window, internal vaginal examinations to assess tone are clinically discouraged.
Because the structural matrix is just too vulnerable.
Exactly. The protocol focuses heavily on horizontal rest to remove the vertical load of gravity from the viscera.
Right, because you are trying to minimize the intra-abdominal pressure that is constantly pushing down on a healing wound.
Yes. If you spend those first few weeks standing, carrying a baby, pushing a stroller, well, gravity is forcing your internal organs to bear down on that wet concrete.
Which is just a recipe for disaster. So rather than assessing tone, the goal in the first 6 weeks is really just gentle reestablishment of the neuromuscular connection.
Right. Simple diaphragmatic breathing and isolated 30 to 50% effort pelvic floor contractions.
Just to remind the motor cortex where the muscles even are.
Exactly. Formal assessment of laxity is completely off the table.
Okay, so then we hit the 6 to 8 week mark. We've established the tissue is nowhere near healed, So this appointment isn't about finding a final verdict, right?
No, definitely not a final verdict. But this is the gold standard window for an initial screen to establish a baseline.
Cool.
You go to a specialized pelvic floor physical therapist. They check how the superficial scar tissue is organizing, and they evaluate if you can physically execute an isolated contraction.
Got it. And this is also the appropriate window to introduce clinical self-assessments, right?
Right.
Like the EPAQ.
Yes, the EPIQ, the Electronic Personal Assessment Questionnaire.
Okay. And what exactly does that do?
Well, it's a validated diagnostic tool widely used in the UK to measure the subjective impact of pelvic floor symptoms, including laxity, on your overall quality of life.
Okay, so it gives the clinician a detailed map of what symptoms are bothering you today.
Exactly, today, but it does not predict what your pelvic floor will function like in 6 months.
Right, because the true diagnostic picture doesn't even begin to emerge until the 3 to 6 month window.
Exactly.
And that aligns perfectly with how people actually live their lives. Because 3 to 6 months is usually when the physical load drastically changes.
Yes, that's when people usually attempt a return to higher impact exercise or, they're constantly lifting a rapidly growing, much heavier infant.
And pelvic floor function is entirely relative to the load placed upon it. Walking to the kitchen at week 4 doesn't expose a weakness. But attempting a box jump or a heavy deadlift at month 4 absolutely will.
Absolutely. So at this point, the clinical focus transitions from assessing static resting tone to assessing functional coordination under pressure.
And the physiotherapy protocols highlight a brilliant DIY assessment for this specific phase, right? The balloon test.
Yes, the balloon test is fantastic.
Yeah.
Basically, you lie supine on the floor, your hips and knees bent at 90 degrees, and you blow up a standard balloon.
Okay, I have to say, the biomechanics of why blowing up a balloon while lying on the floor reveals pelvic floor laxity are just fascinating.
They really are, because when you exhale forcefully against resistance, like the tight rubber nozzle of a balloon, your diaphragm forcefully pushes downward on your abdominal organs.
Right. And your viscera have nowhere to go but down, directly loading the pelvic floor muscles.
Exactly. Now, in a healthy, coordinated neuromuscular system, your deep core and levator antemuscles anticipate this spike in pressure.
So they fire reflexively milliseconds before the pressure actually hits the tissue.
Right, creating a firm closure and an upward lift to counteract the downward force.
But if you lack that neuromuscular coordination, or if the fascial tissue remains truly lax, you won't feel that upward closure.
No, you won't. You will feel a distinct downward bulge.
So the intra-abdominal pressure essentially wins the internal tug of war, pushing the pelvic floor outward.
Precisely. It's an incredible... Exactly.
Now, we do need to pause the chronological discussion for a really critical clinical caveat here.
Yes, we definitely do.
If you are 2 weeks postpartum and you experience a sudden inability to empty your bladder, or you feel a distinct visual bulge at the vaginal opening, you do not just stay horizontal and wait for the 6-week baseline appointment.
No, absolutely not. The clinical pathways are very strict regarding acute complications. Red flag symptoms override the delayed assessment timeline entirely.
What kind of red flags are we talking about specifically?
Well, if you experience urinary retention, heavy bright red bleeding, signs of infection like foul-smelling discharge, or a sudden, severe, visually obvious prolapse.
Right. Those require urgent or semi-urgent medical review.
Exactly. Depending on the severity of the symptom, you need to be evaluated within 12 hours to 7 days. In those instances, clinicians are looking for active, dangerous complications, not casually assessing baseline laxity.
Okay, that's incredibly important. But assuming you are on the standard recovery path without any red flags, you respect the timeline. You allow the type 3 collagen to remodel, you establish your baseline at 6 weeks, and you perform functional coordination assessments at 3 to 6 months.
Exactly.
But if laxity is definitively identified as an ongoing issue at that 3 to 6 month point, the question becomes, well, how do you actively rebuild the architecture?
And the clinical consensus across all the guidelines points aggressively to pelvic floor muscle training.
But we need to heavily differentiate clinical pelvic floor muscle training, or PFMT, from the, simplistic idea of just doing 50 Kegels while sitting at a traffic light.
Oh, absolutely. True PFMT, guided by a physiotherapist, is profound neuromuscular re-education.
It's literally motor control training.
Yes.
The balloon test showed us that reflexive coordination matters significantly more than raw, isolated power.
Exactly. Because if the pelvic floor muscle is technically strong but fires half a second too late when you sneeze or jump, well, the system still fails to support the load.
Right. So the training focuses heavily on rebuilding the cortical map in the brain.
Yes. You are training the fast-twitch muscle fibers to react instantly to sudden spikes in intra-abdominal pressure.
While simultaneously training the slow-twitch fibers to maintain endurance and support the viscera throughout an entire day of standing and walking.
It is a lot of work. It requires immense, often frustrating consistency. It typically takes anywhere from 6 to 16 weeks of progressive loading just to demonstrate physiological, measurable changes in the muscle belly.
Right, and 16 weeks of diligent physical therapy is a notoriously hard sell when we are constantly bombarded with marketing for energy-based devices.
Oh, the laser treatments.
You're right, the lasers, the radiofrequency wands, these heavily promoted vaginal rejuvenation clinics that promise, a 15-minute technological fix for laxity.
Yeah, it's very tempting. The marketing is highly persuasive because it targets the precise exhaustion and vulnerability of the postpartum period.
Totally.
However, looking impartially at the clinical protocols and regulatory guidelines, the medical narrative shifts dramatically.
Oh, definitely. Like in the UK, the National Institute for Health and Care Excellence, or NICE, they actually classified these energy-based devices as investigational.
Right. They are explicitly not approved for routine clinical use in treating vaginal laxity.
And the investigational label means the robust, long-term, double-blind trials demonstrating genuine efficacy and safety, well, they simply don't exist yet.
Exactly. And the underlying premise of these devices is that by inducing thermal damage, essentially controlled heating of the vaginal tissue, you trigger a localized inflammatory response.
Right. And that inflammation forces the body to rapidly lay down new collagen, thereby tightening the superficial layers of the vaginal canal.
But forcing a thermal reaction does not rebuild deep muscle architecture.
Right.
It does not train the levator ani to reflexively contract against intra-abdominal pressure.
So it's a very superficial fix.
Yes. Furthermore, the U.S. FDA has issued stark public safety warnings regarding these devices, noting significant documented risks including severe tissue burns, vaginal scarring, and persistent chronic pain.
Wow. And the regulatory pushback is accelerating globally, isn't it? The sources note that in 2025, Australia's Therapeutic Goods Administration actually went so far as to cancel regulatory approvals entirely for devices marketed specifically for vaginal rejuvenation.
Yes, citing the lack of compelling safety data.
The data really just consistently points back to fundamental biology. You cannot shrink wrap a dynamic, load-bearing muscular system and expect it to regain functional coordination.
No, you can't. Thermal tightening of the superficial mucosal layer does not and cannot restore the deep biomechanical integrity of the pelvic floor muscles.
Exactly. Well, we've covered a tremendous amount of ground navigating this timeline today.
I really have.
So, just to synthesize the journey for everyone listening, vaginal laxity is largely a subjective sensation, often conflated with anatomical prolapse or triggered by the asymmetrical pulling of scar tissue. And because childbirth requires the pelvic floor to stretch up to 250%, aided by the lingering hormone relaxin, and repaired initially by weekday, type 3 collagen assessing true laxity in the first 6 weeks is literally measuring wet concrete.
Perfectly said.
The initial structural baseline happens at 6 to 8 weeks, but true functional coordination, tested under the load of your daily life, should be assessed around 3 to 6 months.
Right.
And rebuilding that biological foundation requires dedicated neuromuscular re-education over a period of months, not a superficial thermal fix.
Exactly. And, as we step back and look at this entire recovery landscape, there is one final profound piece of medical reality in the literature that fundamentally shifts how we should view postpartum bodies.
Oh, please share.
So when researchers track the long-term recovery of the levator hiatus, that's the primary opening in the pelvic floor musculature, they find that by 12 months postpartum, the opening typically recovers to a size comparable to someone who delivered via cesarean section.
Okay, so it does undergo massive cellular repair.
It undergoes incredible cellular repair. However, the longitudinal data also shows that the levator hiatus never fully returns to its exact prenatal size.
Never.
Never. The structural architecture of the pelvis is permanently biologically altered.
Wow.
So fighting to bounce back to a physiological state that no longer exists is basically a battle against the fundamental reality of human tissue.
That is so powerful to realize.
The far more effective evidence-based goal isn't to force your body backward in time. Instead, it's about utilizing that long timeline to build the absolute strongest, most functional, and highly coordinated version of your new post-pregnancy anatomy.
Which is such a liberating way to approach recovery. Thanks for walking us through this deep dive.